Hello, and welcome to this short series of lectures covering some of the environmental emergencies within the FR Chem curriculum. Although not a comprehensive review, we will cover the topics at a level of knowledge expected for a UK emergency medicine trainee. The first of these topics is envenoming injuries typical for the UK. Although not apparently common presentations within our emergency departments, envenoming injuries covers a broad range of organisms and clinical entities that we may well come across. Many words such as venom, poison, and toxin are often used interchangeably, so we will begin with some definitions. A poison is any chemical harmful to one or more organisms. Toxins are poisons derived from living cells and are synthesized by metabolic processes. Venoms are a specific group of toxins that are introduced by a wound. They can be introduced by a number of means, including teeth, spines, stings, or claws. Many venoms contain components that are not stable within the gastrointestinal tract and are not always poisonous when ingested. So, a venom is a toxin and a poison, but not all poisons or toxins are venoms. This quote from Dr. Jenner at the Natural History Museum puts it far more succinctly. If you bite it and you die, it's a poison, but if it bites you and you die, that's venom. Venoms are complex cocktails of proteins, peptides, amino acids, and neurotransmitters. This graphic shows just some of the component parts of the venom of bees, wasps, and ants found commonly within the UK. Although we would not expect you to remember the makeup of any venoms, what this graphic does show is just how complex even UK insect venoms can be. Many of the active components you will no doubt recognise, including histamine, dopamine, serotonin, and noradrenaline. The components of venoms vary considerably between species, but also geographically within the same species. The ways of describing venom varies between species, such as snakes often being organised by the predominant clinical effect, such as neurotoxic venom or hemotoxic venoms, while spiders are often described with the clinical syndromes they cause, such as latrodectism or funnel web syndromes. Please feel free to pause the video and review this slide if needed. Having mentioned the venom of ants, bees, and wasps as some of the most familiar envenomations within the UK, we are now going to look at a few less common species we may come across and then discuss a management strategy for all envenoming cases. The UK has one single species of indigenous venomous snake, the European or common adder. They are often found in open habitats such as the moorlands of Yorkshire. They are not an aggressive species and will often shy away from human or animal encounters. At about 70 centimetres in adult length, they are characterised by this distinctive zigzag pattern along their back. Although bites from the adder can be serious, they are usually limited to local effects of pain and swelling. Currently, it is estimated there are between 50 and 100 bites per year from the adder within the UK. Although the adder is the only indigenous species of venomous snake in the UK, we have a significant number of people and institutions keeping exotic venomous snakes. A National Poisons and Information Service report revealed 321 exotic snakebite injuries in the UK from 2009 to 2020 and involved 68 different types of exotic snakes. 17 severe cases required antivenom and there was one fatality. A DEFRA license is required to keep venomous exotic snakes, but many are kept at homes illegally, unregistered. This means it is difficult to know exact numbers found within the UK. While many spiders and scorpions are kept as pets within the UK, the most common captive species of tarantulas and emperor scorpions are not venomous to humans. The UK has a number of species of false widow spiders, and there have been many case reports of venomous spiders being found travelling to the UK from all regions of the world along the global trade network. Therefore, it is possible we may encounter spider venomous bites. British coastal waters contain few venomous fish, but the weaver fish is one of the most common clinically encountered for those working along the UK's coastlines. Often buried in the sand, they have a sharp venomous spine along their back that can easily be stepped on by swimmers and surfers. The management of any envenoming is similar to that for poisonings we would otherwise encounter in clinical practice, but with the addition of the local effects and of a wound. We should always begin with an ABC approach to the patient, making a systematic examination and resuscitation as required. The most common life-threatening effect of any envenomation is anaphylaxis, with 50% of all adult cases of anaphylaxis in the UK being due to insect stings. These should be managed as a standard anaphylaxis case. Massive extravasation into limbs may occur during some envenomations due to coagulopathies and local wounds. Specific to the local and wound effects of an envenomation, the affected limb should be kept still and supported. Jewellery or constrictive clothing should be removed or cut to avoid constriction with any swelling. The leading edge of any erythema or necrosis should be marked, and limb circumference should be compared with an uninjured contralateral side. Although the local swelling and pain of many venoms can mimic a compartment syndrome type picture, the need for fasciotomy in snake bites is rare. Pain is a predominant feature in many bites and stings, and a combination of paracetamol, opiates, and local anaesthetics should be used as required. Senior help for all envenomations is available from the National Poisons Information Service, and all serious or rare cases should be discussed with them. In order to provide the most appropriate advice, knowledge of the species involved is important. It is essential for a snake species to be correctly identified before antivenom can be selected. Please write down any common and Latin names given to you from the patient for any species involved. And it may be helpful for a patient who is the owner or keeper of a species to speak directly with the NPIS consultant. The UK stocks 18 different snake antivenoms, and these can be selected after discussion with the NPIS consultant if required. Anaphylaxis to antivenom is very common, and they should only be administered where full resus services are available. Anecdotal stories and folklore surround many envenomations across species. We're just going to clarify now a few cases. For jellyfish, the UK coastal waters contain a number of jellyfish, and if affected, an area should be rinsed with seawater or saline, not fresh water. This will remove any adherent nematocysts without further releasing any venom. Snakes and tourniquets. For most envenomation injuries, except in a few very specific situations, a pressure immobilization bandage or tourniquet is contraindicated. Cutting out stings. Do not cut out or cut into any stings. Infiltration of sting or bite sites with local anaesthetic or a regional nerve block may be required to relieve intense pain. And so finally, for those of you that thought you'd never come across an envenomation injury, the stinging nettle, the UK's most widespread and commonly encountered venomous plant. Fortunately, although most of us have encountered this, effects are usually just local and topical relief can be applied. Again, please feel free to pause this slide if this interesting detail is something you wish to read. So in summary, envenomation injuries should be addressed with an ABC assessment and resuscitation of the patient. Venoms are complex and often carry multisystemic effects. Get specialist help early in serious or rare cases. I hope this brief overview of envenomations has been useful to you. Please feel free to reflect on it in your own portfolios. If you have any further questions for me on particular envenomations or cases, or would like to see something covered in more detail, please leave in the comments below. Thank you.